Hi, and welcome to the podcast on management of hip disorders and hip surgeries. So before we get into talking about problems that are specific to the hip, I want to talk about clinical practice guidelines. These are guidelines that have been created by experts in the field. What occurs when these are set up is they get individuals who have done a lot of research on a specific area, such as treating individuals with Achilles tendinopathy or individuals who have hip osteoarthritis. And these individuals get together and look at all the evidence that has been created on treating and diagnosing these injuries. They utilize the ICF model, and they help to identify interventions to help address the impairments. How they go about this is they look at the level of evidence between 1 and 5. Level of evidence that is graded as a 1 has high quality diagnostic studies. Often they have a control group and a trial group. The groups have been randomized, or they can use systematic reviews. Level 2 are lesser quality diagnostic studies. So these may have no blinding, improper randomization, or less than 80% of the participants that started the test end up finishing the test. Level of evidence graded as a 3 are case-controlled studies or retrospective studies. Level of evidence 4 are case series, and 5 are expert opinions. So with this, they look at the evidence to support or refute either a diagnostic test, a method of diagnosis, prognosis, or interventions. And they determine if the evidence provides strong evidence. They rate that as an A. And this is when they have a preponderance of level 1 and some level 2 studies to support that recommendation. B, grading the evidence as a B, is that they have high quality randomized control studies with level 2 studies. Weak evidence is that they may have a single level 2 study, but most of the evidence to support that is a level 3 or 4. Grading of a D is conflicting evidence, which may indicate that some studies show that treatment benefits the patient, where other studies show that that treatment does not benefit the patient. Level of evidence as an E is theoretical or foundational, indicating that the science says this should work, but we don't have studies to prove that it does. And level of evidence F is expert opinion. All right, the first problem we're going to talk about is hip joint hypomobility, and more specific, the non-surgical management of individuals who have decreased motion in their hip. Some of the related pathologies are often osteoarthritis or post-immobilization hypomobility. Those with osteoarthritis, this usually occurs with the typical aging process, with joint trauma or repetitive stresses. Also, those who have obesity or hip developmental disorders often get hip osteoarthritis. Post-immobilization hypomobility occurs in the hip joint like it would any other joint. So if you have a disorder where you cannot move your hip as normal, you end up getting tightness around the joint, in the joint capsule, and in the muscles that surround the joint. All right, common impairments that are seen in individuals with joint hypomobility are pain, especially in the groin and in the anterior thigh. Stiffness after rest. I know Dr. Hartshorn talked about hip osteoarthritis and how individuals tend to be more painful if they've been sitting for a long period of time. These patients will have a capsular infield with their range of motion, so limited range of motion. They also will have antalgic or painful gait. And these patients tend to develop impaired balance and postural control and are at a higher risk of falls. So what do we do for management of these patients? In the protection phase, so the earlier phases when we get this patient, our main focus will be for patient education and getting them to be safe with their daily tasks. And this will include educating them on how to appropriately perform ADLs without increasing risk of injury or risk of falls. We want to decrease their pain at rest, and this can occur through joint mobilizations, grade 1 and 2, decreasing pain during weight bearing, using an assistive device such as a cane if it's a unilateral problem, or a walker if they need more assistance or if it's a bilateral problem, and to decrease the effects of stiffness and maintain available range of motion. With this, we would make sure that we teach the patient to perform frequent range of motion throughout the day and not stay in one position too long. Non-impact activities such as swimming or gentle water aerobics are beneficial to these patients, as well as activities such as stationary cycling. So we want them to continue to move. We just have to limit the repetitive stress on the joints. As the patient progresses into the controlled motion and return to function phase, we want to progressively increase the amount of joint play and the amount of tissue mobility that is present. So we may progress to grade 3 and 4 mobilizations and continue with stretching. We want to improve joint tracking and make sure that there is pain-free range of motion. Treatment techniques such as mobilization with movement can help with this. We also want to improve their muscle performance and their supporting muscles, ensuring that they have the balance and the aerobic capacity to return to their functional tasks, and continue to educate the patient on how to decrease the stress on their hip while still maintaining strength and mobility. All right, what does the clinical practice guidelines say? So I put many of these clinical practice guidelines on Blackboard under the additional documentation, or I'm not sure what the tab says, but you'll find many of the clinical practice guidelines. So when it comes to diagnosing individuals with hip osteoarthritis, there are great clinical guidelines that we can use as a PT. So somebody that has pain during weight bearing, stiffness in their hip in the morning, internal rotation less than 24 degrees, and limited hip flexion with a 15-degree difference from the non-painful side is a good indication that a patient might have osteoarthritis. There are also outcome measures, and most of the ones listed here are the patient outcome measures where the patient completes a documentation, so the self-assessment. Outcome measures such as WOMAC and the brief pain inventory help to assess a patient's pain who has hip osteoarthritis. Those that can help assess function also include the WOMAC, the LEFS, which is the lower extremity functional scale, or the HOOS, which stands for the hip osteoarthritis outcome scale. So what has good evidence? So in interventions, those that have a good evidence to support the use of include flexibility exercises, strengthening, and endurance exercises. So a lot of what we have been learning to do in here. Those who have a grade of B, so still good evidence but not as strong research background as patient education on activity modification, on exercise, weight reduction, and how to unload that joint, and also modalities. But modalities help for short-term pain relief. They may not change the overall course of a patient's treatment. Interventions that are graded as a C are manual therapy, gait and balance training, and weight loss. Now, I've talked about evidence A, B, and C. It doesn't necessarily mean that A is better than C. We are saying that A has stronger evidence to support it than C. We will talk about or I've talked about it, and I don't know if y'all have heard me say, back when I went in PT school, there was little evidence to support anything we did. So as a profession, we are fairly early in developing research that supports what we do. So it doesn't necessarily mean that something with a C is not as useful as something with an A. It may mean that we don't have a lot of evidence to support it. What gets a F is bracing. It's We don't have evidence to support that at this time. And realize F is expert opinion. So there have been people who there have been therapists that treat patients with hip osteoarthritis with bracing, and they feel it works. We just don't have the evidence to support that at this time. All right, now I'm going to talk about chondroplasty or microfracture of a joint. So the indications, when an individual has a osteochondral defect, which is what you see here on this arthroscopic image, and they're having pain, the doctors will do something called a microfracture of the area. We talked about this in earlier chapters, but with a microfracture, they go in and cause bleeding in the subchondral bone. That will stimulate growth of this fibrocartilage that will replace the damaged hyaline cartilage. I'm going to skip to the next slide. So osteochondral lesions can be graded. There's two different scales. They go from a grade 1 to a grade 4, depending on the amount of damage there is. So in the Ousterbridge grading, I think I said that right, if you just have softening and swelling of the cartilage, that's considered a grade 1, all the way up to a grade 4 where you have complete erosion. All right, so when we're treating an individual who has had a microfracture or chondroplasty, they're typically non-weight bearing for 8 weeks. So I want you to think about why they would be non-weight bearing and why we need to protect that joint if they had a microfracture of the hip. We want early motion. So again, why? Why do we want early motion? We should want to start remodeling that cartilage and getting the surface to mold in the position that we want it to mold in. Additionally, early we can work on impairment-based treatments, but we still need to follow the principles of healing. So if a patient has a goal of going up and down stairs and they're 3 weeks post-op, we know that they need to be non-weight bearing for at least 4 weeks, sometimes up to 8. And so we can work on muscle function without working in a closed chain weight-bearing status at this point. So what are the outcomes for this? Those who had a grade 1 or 2 lesion tend to have really good results, and they can return to sport and they can return to regaining cartilage. When the lesion gets bigger than a grade 1 or 2, the results aren't as good. And another surgery that can be performed in the hip is a resection or repair of the labrum. If they repair the labrum, you have to protect the area a little longer to allow healing of the repaired tissue. If you resect the labrum, the protection doesn't have to be as great. Typically, the repair is selected when it's more of an acute problem or an individual is younger and has a healthier hip that they hope that they can save the entire labrum. If the patient has a repair of their labrum, they're often non-weight bearing or partial weight bearing for approximately 4 weeks. If there's a resection of the labrum, they may be partial weight bearing initially due to either pain or poor quality of control of their lower extremity musculature following surgery, but they can progress to weight bearing much sooner. All right, so rehab. I just talked about weight bearing restrictions on repair versus a resection. So range of motion, you do want early range of motion, but you need to know where in the range of motion that you're going to put stress on that hip that has been repaired or resected. Often there's a limitation of 90 degrees to protect that repair site. So with strengthening, you want to begin with isometrics, progress to resisted and non-weight bearing, and then you can progress to weight bearing exercises. Aquatic exercises are also great to decrease the amount of weight bearing on the joint, but you have to wait until that incision heals. You can't put an individual in a pool knowing they have an open incision. During the second phase of rehab, where you're trying to gain controlled movement, you can progress core strengthening, continue lower extremity range of motion and strengthening, and begin to work on stability and a balance progression with these patients. At this point, you work on their impairments, but you again need to take into consideration the stages of healing and where they are in that healing process. Once you are allowed, you can progressively increase the amount of weight bearing on that joint. And in phase 3, the return to function phase, begin single leg stance activity and work on proprioception and balance. You can gradually increase the stress on that hip, so moving from non-weight bearing, partial weight bearing, full weight bearing, and then you can start more dynamic exercises. Usually in these individuals, you can start plyometrics and running activities around 4 months. All right, osteoplasty and rim trimming. When a patient such as this picture here on the right has a bony block, they can go in and remove that doing an osteoplasty, or it's also called a rim trimming. It reduces the structural abnormality. This can be on the acetabulum, such as on the right, or on the femoral head, such as here on the left. Sometimes it's both. Many times it's both. And so what they do with this surgery is they decrease the abutment of this bone on the femur to the acetabulum, or this bone on the acetabulum to the femur, or if they have both, you don't want them bumping up against each other and hurting. All right, so how do we treat these individuals? We need to maintain decreased weight bearing to allow for that bony healing. They've shaved away some bone, and we have to progressively increase the weight bearing, but not too much at the beginning. Often they're toe touch weight bearing for up to 4 to 6 weeks, and then you progress to partial and then full weight bearing. You need to use ambulation aids such as a walker to help with joint protection. And you can perform active assistive range of motion at about 2 weeks. You can do active assistive in a protected range in about 2 weeks, and usually by 4 weeks you can allow full range of motion. Right, for strengthening and balance exercises with these patients, once active range of motion is permitted about 2 weeks, you can begin to start some resistive exercises in the active range of motion. But again, you have to remember that you are protecting weight bearing. You want to avoid straight leg raises for 3 to 4 weeks post-op, because straight leg raises put a significant amount of compression on that hip joint. When they are weight bearing, once they're allowed to, you can begin weight bearing exercises and balance and proprioceptive exercises. All right, total hip arthroplasty. You guys have learned a lot about this already from your acute care class. So indications from surgery. People who need a total hip replacement have had osteoarthritis that was not helped with conservative measures. They can have rheumatoid arthritis or other kinds of traumatic arthritis. They may also get osteonecrosis or avascular necrosis, where the neck of the femur wears out and disappears pretty much. Often individuals who broke their hip and the hip does not union together or heal may be a candidate for a hip osteoplasty, as well as individuals who have bone tumors, or have failed other management treatments such as the osteotomy, or the osteoplasty or bone resurfacing that I just talked about. Now, historically, they have said that a total hip replacement will last about 20 years. And again, the ones from 20 years ago or so are wearing out now. So they try to postpone doing total hip replacements until a patient is of older age so they don't have to get a second one. However, there have been a lot of advancements in how they design a total hip replacement, from the components, the materials, how they fixate it. And so total hip replacement is becoming more of an option for individuals who are younger because they feel they're going to last a lot longer than previously. So in this x-ray, as you see here on the left, that is bone on bone. There's not a bit of space. Looks like there's a osteochondral lesion here on the acetabulum, and maybe even one there on the femur. And so in a hip replacement, they replace the acetabular component here. They put a little cup in, and they also put a femoral component in. the head of the femur is gone. So preoperative management. In a patient who we are seeing preoperatively, say they have osteoarthritis, we already discussed how to treat that. Say you get an individual walking in the door and you know they're getting a hip replacement. The surgeon has sent them to you for preoperative care. Here are some of the things that I've always done. The place I work does a lot of pre-op surgery PT visits. So the patient comes in and they're getting a hip replacement. They give you the date. You want to teach them everything they need to know following surgery. Teach it to them before surgery. It is difficult to learn when you are painful, you are on medication, you're having to learn how to do everything new for the first time. So I always taught patients 3 or 4 exercises that I thought would benefit them immediately after surgery. Things like quad sets or glute sets or even core activation, ankle pumps to help prevent a DVT. So also, if you find that they are having significant impairments, they have a muscle tightness or a significant weakness, it's okay to work on that before surgery. I also like to teach the patients how to ambulate with the assistive device that they're going to use after surgery. It is better if they have a walker and they can go around their house before surgery to make sure they can get in and out of every room, get in and out of the bathrooms. They have a clear space into their bedroom, into their kitchen. And so having them practice walking with a walker before surgery is important. In addition, make sure they can go up and down stairs before they're trying to get into their house for the first time after surgery. All right, you learned about cemented and cementless fixation during acute care, but I'm going to review. So individuals who have a cemented total hip replacement can weight bear early. They don't have to wait for the bone to grow into the prosthetic. Where cementless, you have to limit weight bearing and wait for the bony growth to occur to make sure it is fixated. Why would we do one over the other? Well, now we have found that individuals who are older and we can weight bear faster tend to recover a little faster. One of the problems with cemented is that over time, especially with heavy use, they wear out and loosen easier. So if an individual is younger and we know that they're going to use their joint a lot, maybe higher stress, they may want to take that longer period of time during rehab and do a cementless. Where if an individual is older, you're not worrying about high levels of stress on that hip, they will probably do a cemented. All right, there's several different operative methods, a anterior approach, a posterior lateral approach. Again, I know you guys discussed this in acute care, so I want you to go back and review the hip precautions or the movements that you're not allowed to do following different surgical approaches. Also, there's a minimally invasive approach. And while this surgery is more technically challenging for the physician, it does decrease the amount of blood loss, the amount of postoperative pain, and the length of hospital stay. There is a more rapid functional recovery in these patients. The exact surgical technique for a minimally invasive surgery depends on whether they're taking the anterior, the lateral, or the posterior approach. So in a total hip replacement, they take the patient and while they're in surgery, the hip is dislocated and the femoral neck is removed. The implants are then placed, either cemented or non-cemented. The hip is relocated back into a place and the joint capsule is then repaired surgically. This implantation and the components can again dislocate. That's why we have those hip precautions. All right, what complications can occur from a total hip replacement? So there's intraoperative complications. They can include bad positioning of that replacement. They can fracture the femur. The leg length is often not exactly the same following surgery, or they can have a nerve injury. I've seen many patients with who've had a hip replacement, I've seen one patient who had a sciatic nerve injury, and probably 4 or 5 that had a fracture that occurred during surgery. The fractures heal. The patient's nerve injury was slowly improving, which shows really good signs of that it will eventually heal. I didn't see her. I only saw her for a few weeks, so I don't know the complete outcome of that. All right, early postoperative complications. Anytime the patient has a major joint surgery, they are more at risk of getting infection or DVT. Often pneumonia can occur, especially if the patient's not moving around like they should be or like they were before. Late complications include loosening of those components. They can get heterotropic ossification, so bone where they shouldn't be, or other loosening of the component within your joint. All right, let's talk about hip dislocations following surgery. They are pretty rare. Again, I can think of all the total hip patients that I've seen. I've only seen one that had an active dislocation, but he also had, before surgery, no control over his leg. So he had a nerve injury where he couldn't control movement in his leg. The doctor did a hip replacement anyway, and he came in and stood up on what I would call his good leg, and it was obvious that his hip was dislocated. So we immediately sent him to the hospital. But hip dislocations do occur. I have seen patients who have dislocated in the past, and then we are seeing them for their second or third surgery. They are common. They are no, they are not common. They are uncommon, but they are most common in that posterior direction. So that's why the posterior lateral surgery has a higher risk of dislocation. One of the other complications is leg length inequality. So right after surgery, this doesn't concern me as much because patients are typically walking with some muscle spasm or in an abnormal posture, and it's hard to gauge whether this leg length discrepancy is something that will affect them. As time goes on, if their leg length differences are greater than 20 millimeters, that's when doctors consider that normal. One thing though, early, especially both cemented and cementless, you may get the leg may be longer early, and as the patient progressively weight bears, it may shorten as that prosthetic settles into the femur. So something to note on early rehab for total hip arthroplasty, but it may be something that resolves itself, especially if the new surgical the side of the surgery is longer than the other side. All right, so how are we going to treat individuals who have a total hip arthroplasty? So we want early mobilization, and I'm not talking about joint mobilization. I'm talking about getting up and mobilize the patient and have them moving. You must continue to follow weight-bearing restrictions. So if it's cemented, they probably are full weight-bearing immediately. Now, just because they're full weight bearing doesn't mean that the patient, one day out of surgery, will have full control of their leg. They're still going to need a rolling walker or a standard walker, something to assist them. You want to work early exercises to be able to first get them to control getting in and out of a bed, getting in and out of a chair, being able to ambulate, those kind of functional retraining. But as the patient progressively gets stronger, then you're going to look at more specific impairments and activities of daily living and activity limitations. So there are many people that feel an accelerated rehab program, getting the patient, especially the younger patients, to full function early is important. Just realize there's a concern that if you remove the cane and get them to do higher level activities early, you may be limiting this patient more. You want their ambulation to be normal. You want their strength to be functional and well controlled. And so faster isn't always better. All right, exercises following total hip. You want to consider range of motion within what is allowed post-op. Work to decrease any muscle guarding, but also work to increase any muscle weakness that you see. improve their postural stability, improve their balance, and improve their functional mobility. And when it comes to outcomes, I encourage you to go into your book and read the different outcomes. There's good evidence to support that individuals who get a total hip replacement have benefit from that. They have decreased pain, increased function, but there's not great evidence on either side to say how much PT needs to be involved in the rehab process. So fortunately, there's not evidence that says we shouldn't be, but there's not a whole lot of evidence saying that we absolutely have to be part of it. So go through and read several of those studies for me. All right, a hemiarthroplasty is part of a hip replacement. So they either have the femoral component here and not the acetabular component. The one on the right here shows a total hip replacement, where the one on the left here is a hemiarthroplasty. Or on rare occasions, they'll get the acetabular section but not the femoral section. Typically, this is exactly what you expect with a hemiarthroplasty. These individuals pretty much are treated just like someone who has a total hip replacement, so no major difference. Now we're going to talk about hip fractures. The location of the hip fracture is important. So extracapsular is on this left side, so it's outside of that joint capsule. This is an intracapsular. Often if there's a fracture within the femoral neck and they're worried that there has been disruption to the blood supply, they will do a hip replacement. But hip fractures, even in here, if they don't feel that there is disruption to that blood supply, they will do a surgical repair. So these are different things that can be done. This is a pinning of that femoral neck, and this appears that there has been pinning of the femoral neck as well as fixation along the femur. This individual has had an ORIF of the left acetabulum and then ended up needing a hip replacement. So the ORIF, or the open reduction internal fixation, is what ORIF stands for. So after the ORIF, he ended up having a total hip replacement. On this side, it looked like he broke his femur. So he has an intramedullary rod, or an IM rod, as well as pinning of that femoral neck. And just so you know, this is one of my friends. This is his actual x-ray. And yes, he did break his leg skydiving both times. He broke this one skydiving, had it fixed, went back to jumping, and then broke this one. So he was in his 20s when he got this hip replacement. All right, so who gets these ORIFs? These patients are who, well, obviously broke their hip. You're not going to internally fixate something that isn't broken. The determination of hip replacement versus a hip surgery often depends on what the joint congruency looks like. If there's a lot of bone on bone and the patient may benefit more from getting a hip replacement, they're going to go ahead and do that. But if the fracture is further down the femoral shaft and not within that joint, an ORIF is appropriate. All right, so postoperative management. So things that we need to consider after a patient has an ORIF. One is weight bearing. This is when I often look to the surgeon for weight bearing instructions. The surgeon will know the quality of the bone, where the fracture was, how stable he or she got that fracture reduced and fixated following surgery. Most individuals who have an ORIF of their hip will be non-weight bearing or toe touch weight bearing early. You want to begin exercise and functional training within the limitations that are given for the surgery. Now, these patients don't have to follow hip precautions. They haven't had a disruption to their capsule. The pinning that goes on, I'm going to sneak back up to another slide. This pinning, they don't have to go in and break through the capsule. They have done this laterally to medially, and the capsule is still intact. But if an individual, so there's no hip precautions that need to be followed with an ORIF. Sorry about that. And then exercises. Again, work to begin contracting those muscles. So we want to start with isometrics, quad sets, glute sets, do a lot of ankle and lower extremity mobility to decrease the chance of getting a DVT. But what does the evidence indicate? So a lot of the evidence says that we don't need to limit weight bearing as much as most surgeons do. There's some studies that show that those who were allowed to weight bear as tolerated following surgery had the same outcomes as those who were partial weight bearing. So again, you always have to follow the physician guidelines, but some good education of a physician may benefit the patient, may benefit the patient if you feel that increasing weight bearing is needed. All right, so we're going to talk about some non-operative syndromes, such as, we're going to call it painful hip. So muscular tendinous impairments, such as muscle strains and tendinopathy, are common. I think we have talked repeatedly in this class about how to treat muscular tendinous impairments, and treating them in the hip is no different than treating them in any other joint. They often occur with repetitive trauma. I think of runners or people who do a lot of the repetitive activity. Bursitis are very common in the hip, especially this trochanteric bursa. The IT band comes over top of that trochanteric bursa and can cause some irritation and inflammation. Other painful hip syndromes include femoroacetabular impingement, or FAI, and this can be impingement of the femur onto the acetabulum or bone growth on the acetabulum impinging on the femur. Patients present with pain. They often limp or have a significant amount of gait deviations. They have muscle imbalances and poor neuromuscular control based on adaptation over time because of the pain, and they also end up with decreased muscular endurance. So a normal hip appears like this. A patient can have a cam lesion, which is excess growth on the femur. They can have a pincer lesion, which is excess growth on the acetabulum, but often they have mixed. They get a little bit of both. All right, so what do we do to treat these patients? Whether we're talking about patients with bursitis or a tendon problem or these acetabular impingements, you want to normalize their gait as much as possible. Promote healing and determine what the causes of the irritation are. So if it's a chronic inflammation, find out the causes of this inflammation. If it is a bursa being irritated, try to determine what is putting pressure on that bursa that's causing the irritation and relieve the stress from that.